Assalamualaikum and good morning, good evening. Today I'm gonna present about non-invasive ventilation in a critical ill patient with COVID-19 pneumonia. I am Dr. Mohd Zulfakar Mazlan from the Department of Anesthesiology and Intensive Care School of Medical Sciences, Universiti, Sains, Malaysia. As for introduction, hypoxemic respiratory failure due to COVID-19 is difficult to manage because the timing of intubation is uncertain. The use of non-invasive ventilation (NIV) in COVID-19 is still debatable. However, delay intubation in patients who are indicated for ventilatory support in a patient with PF ratio of less than 150 results in higher morbidity and mortality. A 60-year-old woman with diabetes, hypertension was admitted to the COVID-19 ward in our hospital. She had contact with her husband, who had fever and cough for almost 10 days at home. She had been asymptomatic prior to hospitalization. She became tachypneic on day 4 of admission, and a chest radiograph revealed worsening heterogeneous opacities, which mainly on the right side of the lungs. On day 1 of her admission, she was diagnosed with COVID-19 by real-time PCR, which was day 10 of her first exposure. Serial blood investigation revealed the highest total white cell count of 26, with normal hemoglobin and the platelet counts. The highest CRP or C-reactive protein was 44, and procalcitonin were within normal range, with the D-dimer 0.5, the highest. And the renal profile was normal, except for urea, which was slightly elevated. She required a gradual increase in oxygen supplementation due to progressive worsening hypoxemic respiratory failure from the day 4 until day 9 of admission. She was first treated in the prone position with nasal prone oxygen before being treated with non-invasive ventilation (NIV) by applying nasal mask in an isolation room from day 5 onwards until day 10 of admission. She required fraction of inspired oxygen (FiO2) in the range of 40 to 60% with positive end expiratory pressure (PEEP) of 6 to 8 cm water, pressure support of 4 to 6 cm, Water above the PEEP and tidal volume ranges from 6 to 7 ml per kilo body weight. Her lowest partial pressure of oxygen, PaO2, was 57 mm mercury under 60% FiO2 while on non-invasive ventilation. Her PF ratio was about 95 at that time. In the ward, she was given favipiravir, intravenous methylprednisolone, subcutaneous enoxaparin, tocilizumab, and empirical antibiotic meropenem. She was discharged well after 20 days of hospitalization. As a conclusion, judicious use of non-invasive ventilation in a patient with COVID-19 pneumonia prevents the patient having to undergo intubation and hence avoid the complications of invasive mechanical ventilation. Therefore, NIV or non-invasive ventilation is useful in selected cases of patient COVID-19 pneumonia who require increasing oxygen supplementation. This is the references for my presentation. Thank you very much for your kind attention.